Hi, everyone, and welcome to another episode of the Global PAD Impact Awards brought to you by the Global PAD Association. It is my honor to introduce the recipient of the Online Physician Educator of the Year Award. Which, it's this person has made some great strides in the field of peripheral artery disease, not only achieving remarkable patient outcomes through his dedication to limb preservation, but also helping others do the same. His innovative approach to treating PAD patients combines cutting edge techniques with a patient centered focus, ensuring the highest standard of care for patients with PAD. Now, beyond his clinical excellence, the award winner is a pioneer in medical education, utilizing his At Vascular Disease YouTube channel to share invaluable insights and advanced methodologies with physicians worldwide. Through clear and accessible content, he empowers his peers and even patients with a lot of really great information, but even more importantly, he uses this channel to really help his peers to replicate his success in saving limbs, fostering a collaborative learning environment that elevates the entire medical community. So please join me in welcoming Dr. Srini Tumala, an esteemed interventional radiologist from Miami, Florida, the winner of this year's online Physician Educator of the Year Award. Dr. Dumala, thank you so much for joining us, and a big congratulations to you, as well as a big thank you for all you do yourself to exhaust all efforts to save life and limb, as well as helping other physicians do the same.
Thank you, Kim. I'm honored to be receiving this and quite unexpected, as you can imagine, because it was never my intention when I started this educational, journey. Uh, you do bring up the YouTube channel. I mean, that really what I was trying to get at before is that I started that channel years ago, mainly because I was giving talks to a lot of the trainees, residents, fellows, people in vascular programs across the country, and they were always asking me about, can you send me this talk? Can you email it to me? And as you can imagine, a lot of these talks are very large, files with a lot of videos, and it was very difficult. So I started just throwing them up on YouTube because it was easy for them to access it. And then slowly with time, I realized that a lot of people started watching them. And then I had to put a name to it and give it some level of a logo to make it look a little bit more professional. I mean, when I started the channel, it's really meant for trainees, residents, fellows, and early career physicians who are trying to navigate this really rapidly, evolving and innovative field of vascular disease, which is constantly changing in terms of data, studies, and quality, and how should and guidelines. And one thing I probably am going to focus on over the next 12 to 24 months will be more patient-centered education. I think that's the one place where that we can really make a big difference, because a lot of patients, I was thinking about this the other day, if you're not in healthcare, it is very hard to navigate healthcare, as you can imagine. I mean, I'm in healthcare and I see how difficult it can be. And so if you have no background in anything that you're dealing with or anything that you are seeing, it is very difficult to figure out where to go, who to talk to, what's true, what's not true. And I think most people always think that, well, if it's a doctor, well, they're all the same. If it's a lawyer, I need the best one. If it's a plumber or an electrician or an engineer, who's the best? But when it comes to physicians, not everybody, but there's enough people out there who just assume everybody's the same. And I think you have to realize that just like anything in life, there are some that are great and there are some that are average and some that are below average. And so it's important to really find good people who can, describe things in an easy to understand manner and who can really make you feel comfortable with what you're doing, because you may not always be successful, but you want them to at least feel like they're part of the decision-making process and that they really have a good understanding of what's happening.
And I love that you say that. You've pretty much stated exactly what the Global PAD Association is doing. So, again, we would love to work with you and collaborate on this content. It's what we do every day. We interview doctors every single week, such as yourself, and such as what you signed up for initially without knowing that you were going to be also honored in this What's Up Doc session that we normally do.
Sure.
Doctors like yourself sign up every week to answer the critical questions that patients have. on PAD care, how to find a doctor, how to decide what doctor to go to, and the treatment options that are available. So definitely would love to collaborate with you further on that so we can have it on both channels so that so many more patients can find the information and get what they need to make a better decision on their care. But, I'm really interested. You're just so passionate about PAD, and I'm curious with interventional radiology in particular, there are so many different directions that you could go. I'd love to hear what initially sparked your interest in PAD and how it has actually shaped your career as an interventional radiologist.
Yeah, I mean, I think, part of the reason I went into this specialty was really to help. One of the first mentors I had was in my training in medical school. And when he showed me a lot of the things he was doing, I thought this was just amazing work, not having to open up and operate on people and being able to treat things with really kind of non-surgical, less invasive options. And I think that started my interest. And then when I did my training, I was at a vascular institute and we primarily did peripheral arterial disease and aortic aneurysm work and things related to, blood vessels throughout the body. And that sparked my interest even more. And then I ended up, going to UCLA and doing a neuro fellowship there. So, dealing with strokes and uh, disorders related to the brain, and that kind of just reinforced it. And I think that's kind of been the path or the what's led me to where I am today.
Can you share a personal story about a specific patient whose journey with PAD deeply impacted you and really reinforced your commitment to this area?
Yeah, I mean, I think a lot of it is that there's never just one patient, but I think probably one of the biggest satisfactions I get is when somebody comes to see me and they're told that, look, I've been told I have no other options. There's nothing we can do. And then when we actually go through and do our workup and our evaluation and all the vascular testing that we typically do, that we see that, you know what, we may have an option here to do something to save your leg, or at least make whatever amputation you're going to have less extensive. That's probably the best way to say it. And I see quite a few of those patients in South Florida. I'm obviously kind of west of Fort Lauderdale, so that's where I'm located now. But that's, I think, the biggest, probably gives me the most satisfaction is when we're able to take patients who are told that there's really no other options, and then we're able to make a difference. We're not successful in every case, but at least we took somebody that had a 0% chance based on what they've been told and giving them some level of hope. And I think that's probably the biggest thing. And you got to realize that in this arena, when people say you have no other options, that really depends on the experience of the operator, right? If I'm less experienced in something, then I'm not going to be able to offer, or I may not even know what those things are that could be offered. And if I'm more experienced and have seen a lot more of these things, then I'm able to look at something and say, you know what, there are some options here. So it really depends on who you're talking to. And so I think we have to be careful with this so-called no options patient. And it's what I always tell the trainees and the residents and fellows and the medical students when they're learning, that you might think there's no options, but have we looked at every possibility, and are you aware of all the data that's out there and everything that's kind of new and innovative? So things to think
And
about.
in that case, instead of giving up on the patient, give up the patient. Help
Yeah.
the patient find another option that might be available that you may not know about. What we find is exactly what you said, that
Mhm.
sometimes, actually, most of the time, a doctor may not know what he or she doesn't know because with innovation moving at the speed of light in peripheral artery disease right now, not every doctor can keep up with everything. And we even have some
Right.
patients that are teaching doctors about the deep vein arterialization, which in some community hospitals they had never heard of before. But it's really no surprise. But we were interviewing Dr. Craig Walker, who is also an advanced limb saver, such as yourself. And he actually said that today there are very few actual no option patients. So I'm curious from your standpoint, how would you define a no option patient today with so many advances in limb salvage tools and techniques?
Well, I mean, I think it's tough to say who's the true no option patient at this point. I mean, because what you said was in fact true, and what Craig who I know and has been really a leader in this space for decades and decades, what he says is very true. There's very few patients today that have no options. Now, the question is, some of the options they have may be very difficult to go through. The healing process, the recovery, what symptoms they have afterward as they heal, if you're able to be successful. And some patients don't want to go through that. I mean, let's be honest about it. Not everybody can go through an extensive recovery and things like that. But there's enough people out there who are like, let's do everything we can, and I'll deal with what comes if I'm going to hopefully have a chance to prevent a major amputation. So I think one of the things we have, right now, if you look at all the guidelines, whether it's Europe or in the United States, in terms of guidelines for what is a no options, CLTI or chronic limb threatening ischemia patient. And CLTI is a fancy word for end stage peripheral arterial disease. They have the most severe form of PAD. And those are the patients who are at risk for, as you know very well, Kim, major amputations as well as other things like heart attacks and strokes and so forth. And, there's really no guideline out there to tell us what's a no options patient. And so that's why it gets back to what I was telling you, is that it really depends on the experience of the operator. And that's really the most important thing, is make sure you're with somebody that doesn't just have vascular in the name. That's kind of can be because again, it really depends more on what is the experience and the background and the track record of that physician more than anything else.
A lot of that information is not out there. What questions would you advise a patient who's in our live studio audience, for example, to ask a doctor in the interviewing process during their consult when they're determining, is this the right doctor for me, for my presentation of disease? If you were in that patient's shoes and you were choosing a PAD patient, give me the top questions, and I don't care how technical they are. These patients can handle it. What
Yeah.
are the top questions that you would ask these patients to choose the right doctor for them?
I think there's some easy questions you can ask that don't require any, technical expertise. I think the first one is, one, are you somebody who treats complex below knee and below ankle disease? I think that's the first question you can ask. If you look at all the different specialties that treat vascular disease, there's vascular surgery, there's interventional cardiology, there's interventional radiology, and everybody, and regardless of what specialty they're in, it really depends on their experience and their background. That's probably
Mhm.
the most important thing. But when you look nationally, those are the three specialties who are involved in this peripheral arterial disease treatment space. And so I think one of the biggest questions is, if you talk to someone and say, hey, are you very experienced at complex below knee and below ankle disease? And are you comfortable with all the surgical as well as non-surgical options? If you're not a surgeon, then are you comfortable with all the non-surgical options? And do you feel comfortable referring somebody to somebody that can do surgery if needed? I think those are probably the biggest questions to ask. And a lot of people will look at, well, what medical school did you go to and this and that. But in reality, medical school does not define who the physician is later in life, so to speak. It really comes down to, where did they do their fellowship training, their last part of their training. That's probably is one of the most important things to look at. Where did you do your residency, but more importantly, where did you do your final pathway of training, and what have you been doing since that point? I can train at the greatest place for obstetrics, but if I'm not practicing obstetrics for the next 5 to 10 years and I'm doing something else, it's irrelevant of how great a place that fellowship was, right? So I think it's very important to see that whoever you're talking to, are they well trained in what you need them to do, and do they deal with complex below knee and below ankle disease? I think those are the two big questions I would ask.
I couldn't have said it better myself. We just had a doctor over in Indiana, and I think he had his fellowship at a university that didn't believe in treating below the knee and didn't believe in using an advanced tool known as an atherectomy device, the roto-rooting devices, even when studies have shown they are indicated, or even when the device is indicated for a particular use, such as with rock hard calcium to remove some of the plaque, or number two, instant restenosis, right?
Mhm.
And it's, if you know where that person did their fellowship, you could pretty much know that that person is not going to be a doctor for your critical limb ischemia. If you are end stage, you will realize that this doctor may not have the advanced tools and techniques available to exhaust all available efforts in limb salvage. And I'm thinking in my head, and I will not name them. I can tell you which universities right now, especially in on the East Coast, are training fellows to not perform limb salvage. It's very interesting. But for you in particular, you are a CLI fighter. You are trained in advanced tools and techniques. But I could imagine for you, there are still some Achilles heels. So, what are some of the most significant, challenges that you face, challenging cases in treating PAD, and how do you address them? What are your ones that keep you up at night and go, oh, what am I going to do? How am I going to solve this?
Well, I think one of the Achilles heels that we have is just calcium in general. I mean, I think we have tools that can deal with calcium, but a lot of patients today, because of the explosion of diabetes and really chronic kidney disease, we're dealing not only with multi-level blockages in the arteries, so blockages above the knee as well as below the knee, and now even below the ankle, but we're dealing with heavy, heavy calcification. Not only calcification that lines the inner wall of the artery, but calcification that lines the middle layer and so forth. And this calcium can be so, it's basically like concrete. So think to yourself, if I had a pipe that was filled with concrete, how do I get through that pipe? And once I get through, how do I get, if let's say the pipe is made of a soft material, how do I expand it at that point, right? You can see that that's really one of the limitations. And so when I do a lot of the testing, look, we have a Center for Advanced Amputation Prevention in South Florida is where I'm located now. And we have a lot of different tools, but that's the biggest problem. When I see patients with multiple blockages at different levels, if they don't have a lot of calcium, the likelihood of being successful in terms of opening up the blood vessel and so forth is much higher. On the other hand, if they have dense, dense calcium that's filling the entire inner inside of the blood vessel, those are really patients that hopefully they've got some surgical options and they're probably better off going to a bypass surgery or something like that. And I think so. I think that's really one of the biggest Achilles heel. I think so. Calcium. I think the second factor is also just patient commitment. I think it's, a lot of people you get a lot of patients who have vascular disease. You're seeing all the people who are very interested in kind of taking care of the problem and fixing it, but we have a lot of people that don't think about it, right? And they're not as aggressive about it as well. And so when they finally go see somebody, they have really severe, severe disease, which is much harder to treat than if they had come earlier. And I think that's why the world, especially in the US, is constantly talking about prevention because it's much easier to try to prevent something, even though it's a lot more work. Don't smoke, don't eat this, control your blood pressure, drop, lose weight if you can. There's all these things, but it's not easy. I'm not saying it's easy, but so I think those are the two biggest things that we're having trouble with. I mean, we're really the first outpatient center, I think, in the country, but definitely in Florida, of using a new stent, but although they call it a scaffold, that really keeps blood vessels below the knee open and it dissolves over about 2 to 3 years. And so the benefit now is that we have, a good data to show it's better than a lot of the therapies we have out there. And now we have a bioabsorbable scaffold. You put the scaffold in an artery below the knee, it does its job. It's better than a lot of the other therapies we have available out there in terms of keeping that blood vessel open. And then it dissolves over time, typically over 3 years. And we were one of the first places to put it in the country. And we were very excited about that. So I think we have some new technologies coming around, but we still need more.
Is that the Abbott Esprit stent?
Yeah, the Abbott Esprit. Uh-huh. Yeah.
And how are they doing? And in terms of rolling that out across the country, because we even just had a patient here in the San Francisco Bay Area, and it's not available at this
Yeah.
facility, which is a pretty well-known facility. So I'm curious, we want more and more patients because
Yeah.
to have access to amazing new technology such as this.
I think the way to think about it is that, the company in general is being very careful on how they roll it out and to whom they roll it out, right? They want this to be successful. They want people to, it's not as simple as the typical stent that we're used to, that we just put it in, we inflate it, dilate it, and we're good to go. This requires some training, some background, and there's a difference in technique in terms of deploying it. And because of that, they are making sure that they train all the physicians who want to use it in a very diligent and kind of dedicated and precise manner. I just had a webinar last night for an hour with a whole bunch of doctors who are interested in this, where we talked about the data, how it got approved, what it's used for, when should you use it, how do you use it, and then the technique, because the technique is very different than a lot of the other things that we do. And so it's not something that's hard to learn, but it just requires some training. And I think that's why it's been a more, kind of careful rollout of this device.
It's interesting because I think the companies nowadays, because I've also had conversations with another company that has a very new novel scaffolding. It's a retractable stent called the Spur, and it's already CE marked over in Europe, and they're working on that for possibly 2025 here in the United States. But they're waiting rollout until they get FDA clearance as well. But
Mhm.
in talking to them, they also are being very careful in their rollout and only choosing those doctors, they're being the chooser, choosing those doctors who will take the time to actually learn. My
Yeah.
experience and my foray into this industry was with a medical device company, following them around and documenting the FDA study and overall global commercialization. And the
Mhm.
number one thing that I experienced is the lack of time that doctors would give to these companies to actually learn. I mean, we even had a doctor who said to the CEO, "Hey, I'll give you 2 minutes, tell me how to use it, and then I don't want you to say a thing once we're in there because my reputation's on the line." And it was just this type of mentality across the board that I thought may have led to the failure of that device. And I think that it's so smart for these companies to say, "Hey, if you want these devices, then you've got to really take time to learn how to use them appropriately." And I think that that was the downfall of the atherectomy industry overall,
Mhm.
because so many doctors that I've seen, and I'm on my soapbox, but so many doctors that I've witnessed in nearly a dozen countries, more than 30 states using these, that there were a lot of doctors when they wouldn't have good outcomes, they weren't using these devices as indicated. And it was very frustrating to watch. And I don't know if and that's why I love the fact that you, as a peer, you have this YouTube channel for these doctors, for additional education, for these doctors to be able to use to improve their skill set with all of these different devices and techniques.
I mean, I think, look, I think when it comes to atherectomy, what we have to realize is there's really no randomized controlled trials or head-to-head compare. Well, I shouldn't say that. There's a couple of RCTs for laser and things like that, but in general, there are no head-to-head comparisons on which atherectomy is better, to show that one is better than the other. I think that's the first thing. I think the second thing is, I think a lot of the physicians in the vascular world are really looking for randomized controlled trials, which are the best kind of medical trials you can do on any type of device, product, whatever you're testing. And I think a lot of people are waiting for that. We do know that atherectomy can give us some advantages in the right settings. I
Mhm.
think figuring out what that is sometimes challenging for physicians that are out there because there's so many devices. I think the other thing too we have to realize is that, look, for every doctor that's, bad or terrible or not good at what they do, there's somebody that's great. And I think it gets back to the same thing as, try to find somebody that, you don't need to find somebody that holds your hand and makes you feel warm and fuzzy, but you need to find somebody that is good at what they do and then they can explain things in a manner where you can conceptualize it and understand it. I think that's the most important because then you're more likely to feel comfortable about it and more comfortable about the treatment that you're getting. I think what we have to also realize in this PAD space or this vascular space, there are well described and well written about guidelines on how to treat patients.
Mhm.
Just in 2024, just recently, the new PAD guidelines came out, which was really supported by all the major societies, whether it was surgery, cardiology, radiology, et cetera. And it really gives a nice, and you can Google it, it's the 2024 ACC PAD guidelines.
We
And
did. We just
yeah,
interviewed Dr. Mehdi Shishabor from University
perfect,
Hospital. He was
perfect.
on the team, and he went
Yeah,
through all of the
yeah,
2024 guidelines for us for our YouTube channel. So for those who do want to see and hear what he had to say and explaining those ones,
yeah.
you're definitely welcome to go to youtube.com/the way to my heart. But as you said, they're easy to Google. But what's interesting to me is even over the weekend, I had a patient, it was literally Dr. Tamala, 1 o'clock in the morning, and a bunch of general surgery fellows were pressuring this patient to go through with a full toe amputation for osteomyelitis that's just to the tip, with a little, what, maybe a little curettage could actually, resolve. But they wanted to cut off the whole toe. They didn't want to perform any sort of vascular evaluation. And I got on the phone with them at literally 1 o'clock in the morning, Sunday morning. And I had to explain to them the Society for Vascular Surgery and AHA guidelines and the new 2024 All Society guidelines. And the general surgeon, the supervising general surgeon, actually said to me, "We're not required to follow those." And I
Yeah.
couldn't believe what I was hearing. That these patients, you're right, they need to be empowered with this information. And as soon as we brought that to their attention and we were able to say, also CRP was great, white blood cell count was great. Um, this is more of an elective procedure if you're talking in the middle of the night. I mean, seriously, why are you doing this? And we
Right.
were able to put it past, but I just don't understand, why some of the doctors are not following those guidelines and why that's so difficult to understand. Do a vascular evaluation, at least attempt to restore inline flow prior to amputation.
Or at
Easy
least
breezy, right?
or at least test for. I mean, again, you're hitting you're hitting a major point, which is if you look at the Medicare data, and this was, looked at really several years ago, they looked at all the patients who had amputations. Half of those patients did not get any type of vascular evaluation or testing in terms of an angiogram. And what you have to realize is the majority of patients that have wounds or problems with their legs, they don't really see necessarily a vascular physician. They may see an orthopedic surgeon, they may see a general surgeon, as you stated. And in reality, there are guidelines on how to work up, treat medically, treat with invasive and non-surgical treatments, as well as surgical treatments that are well written about and described, and they're online. You can find them. And so, I think, people really have to follow the guidelines when it comes to treating patients with vascular problems. I think the other
Yeah.
thing too is that I think we've been told I mean, I'm 56 now, so I'm old enough to remember the days of the Marcus Welby, the show on TV and all these shows. And one thing you got to realize, I think the media has kind of made it look like, oh, they're figuring out what's happening. There's art to this. Sure, there's nuance, but there's also a lot of science on how to do things and what should be done where there's not any guessing. It doesn't mean that you'll fall into a specific category or that the treatment or what needs to be done is easy to figure out. But there's a lot of help that's available based on data, studies, and guidelines. And I think we have to realize that, if somebody's telling you, well, I think we should do this, you should say, well, based on what? I think that's the most important. That's one of the important questions you can ask.
And one of the things, I can't tell you how many patients we have sent your videos on how to recanalize the pedal loop that you have done. And when a patient is sitting there and the doctor says it's not possible to treat small vessels below the knee, I just send them. I mean, I have your videos sitting in my notes on my phone, and I have literally sent that dozens of times to patients who are in the hospital where a doctor
Yeah.
says amputation. And they've
Yeah.
used that video to show the doctor, well, if Dr. Tamala can do it, why can't you do it?
Right.
How is
Yeah.
it possible that they're too small to treat when you can see it right here with your own eyes, as I can, that it is possible to treat in the medically appropriate
Right.
circumstances?
Well, what it tells me is that I need to update that talk. That's the first thing it tells me. But I think the main thing with PETA loop, we do have to understand, when you look, there are really no societal guidelines on when to intervene on the PETA loop. There's no societal guidelines on how much of those arteries, like how many do you open? Do you open one? Do you open the entire loop that you're talking about? And there's no guidelines on what those indications are of when to do it. I think, we kind of are reserving it to somebody who's at the last end stage where they're saying, look, we need
Exactly.
a major amputation. we feel there's no hope and we're going to have to do a below the knee amputation. Well, then in that case, we should probably try everything we can to try to either prevent that or limit that type of amputation. Because as we know, once you get an amputation, you're going to get another one eventually. And once you get a below the knee amputation, when you look at the outcomes at 1 year, 2 years, 3 years, out to 5 years, your risk of death and other problems is significantly increased. And so I think the important thing is to find a vascular physician who just understands all these things and is, well versed and has some experience and
Yeah.
follows, guideline directed therapy. I mean, that's the best thing you can do.
Yeah, no, exactly. It's between your video on the pedal loop, and these are for patients, and every single one of them has been on deck for amputation.
Yeah.
And so it's very strategic in terms of who that's sent to. And it's your video, and then also Dr. Zola and Dandu, an interventional cardiologist who was
Right.
formerly of Ochsner,
Yep.
now in East Palatka,
Northern.
Florida.
Yeah.
Right. He's actually north of you.
Yeah.
But that on the deep vein arterialization. And
Yeah.
so it makes it so that these patients have a little bit of hope and can actually say, hey, doctor, is this a possibility? And if you think it might be a possibility, I'd like to find someone within this hospital system that can do a consult with me and review my case and see if this might be appropriate for me. But someone who has the skill set to do it, who could make that proper, not only the proper assessment as to whether it's feasible, but also who can execute accordingly.
Yeah, I mean, without getting into what deep vein arterialization is, it's basically, without getting too detailed, you're basically creating a connection from an artery to the vein that's in the leg. And then you're getting the kind of this high pressure blood flow to go down the vein into the foot, and then it refluxes or goes backwards into the small arteries that then take the blood into the tissues. And so we've had, a lot of data related to DVA or deep venous arterialization over the years. And there are some promising results. I think we need more data, we need more experience with it. But I think it is an option for the so-called no options patient. And I think also that it really requires a big commitment from the patient as well in terms of follow-up and the symptoms they get afterward and the things they have to deal with to see if they eventually get healing. It requires a lot of work on the part of the patient as well. And so, for that, I think it's something we have to look into in the future.
Exactly. We do support and work with some doctors on their DVA patients because there is a lot of follow-up with wound care and it gets worse before it gets better. I mean,
Correct.
those wounds look vicious and the
Yeah,
pain
no, for sure.
gets almost unconscionable, in the first couple weeks. So
It can,
it's really,
yeah. Yeah, and
yeah,
although we obviously want to avoid amputation, I mean, there are some cases where that may be the best thing for somebody in terms of
yeah.
their life and quality of life. But obviously, we want to limit that and prevent that as much as possible.
Yeah, I was just posed with that this morning. That's always a tough question. And this patient said, Kim, what do you honestly think at this point? She's been fighting for 2 years. Someone ended up, her physician, bless his heart, he was trying out the new, Phillips, tax. And he ended up putting in the wrong size, putting way too many of them in, not really realizing. And it just has led to a revolving door of just treatment after treatment after treatment after treatment. And this poor patient is just today was just like, I don't know, I think I'm kind of done. And I said, that's a conversation that is very important to have with your new doctor to
Yeah.
see if this is something that you want to keep going through this revolving door. And it's not just revolving door of treatments, it's the revolving door of excruciating pain
Well, of course,
and not
patients are
looking forward to
suffering, right, that have these wounds. I mean, some of these wounds can irritate the nerves, and then you've got a neuropathy on top of it, and you've
that.
got severe pain. And it's not easy and when you think of wound healing, even after you fix somebody, you're still looking at 3 months of time in best case scenario to achieve healing. And some
Yeah.
of the blood vessels you open up may not stay open for, you hope they stay open for that long, but depending on their diabetes, do they smoke, not smoke, their cholesterol, are they on their appropriate medications? Are they taking the medications? All those things will, how much calcification do you have? All those things will affect how long that these arteries below the knee and below the ankle will stay open. And so, at 3 months, maybe the patient comes in at 2 months and says, "Oh, now I have a underlying bone infection where the wound is." Well, now, you have to possibly start over and say, okay, what's the blood flow look like? And it changes things. So it's not an easy fix for sure for many of these patients that are dealing with this.
For those who are watching, you can definitely see why, Dr. Damala is such a great educator. The way he explains things is just so powerful. And I'm curious, you've probably gotten a lot of feedback about your channel and certain videos. And I wondered, could you highlight just, one or more of your most powerful or influential videos and what makes them truly stand out to other physicians who have offered you the feedback on them?
I mean, I think, again, I think now we have, I don't know, probably 100+ videos, but again, the reason for that initially, as I stated before, was really to educate people. And it's not an exhaustive education, right? What I try to do is showcase topics that I think are pertinent, that people are asking questions about at conferences or when we're just having discussions about things. And it looks like, oh, you know what? This is something everybody's talking about, but nobody's really talking about the basics. And I think what a lot of people do when they give talks at conferences, especially, conferences for physicians who are trying to learn stuff, everybody always assumes everybody knows all the basics about everything. And really, in reality, that's not true. Most people do not when you come to these courses. That's why they're at the course, right? They want to learn. It's not like you get a room full of experts showing up and saying, okay, show me what you got. It's usually people who are either beginners or they're in the middle. And then you get some people who are experts and they want to see if what they're doing is, following what everybody else is talking about. But in general, the mission of the channel was to really showcase to people that, look, this is what is happening in the vascular world, and these are some of the basics. I wish it could be exhaustive, but it's not. And it's not meant to train somebody to where they feel comfortable and they can do this stuff. It's more just to get them thinking about, oh, you know what? I didn't realize that. Well, maybe I should go study this and learn about it and go someplace to get trained and become an expert at it because I can add that to my toolkit, so to speak. So I think that's the main thing. So I think probably some of my favorite videos are the ones I did early on where I was just trying to educate people. And that's really been the mission, just educate people on what's out there. And again, it hasn't been a patient-centric channel, but that's probably something we're going to do in the coming years. So
Yeah, well, hopefully we can collaborate on that and put
yeah,
content on both.
sure, we
But
can
I'm curious, if there's been any memorable interactions though with fellow physicians who've reached out to you after watching your videos, and how did these exchanges actually influence your content or teaching approach?
I think, when I go to conferences and give talks to whether they're medical students or residents, or I train people at the university, fellows and so forth, I've had many, many people over the past couple of years come up to me and say, "Are you Dr. Tamala? I've seen your YouTube channel and I thought that was a great talk," which was really shocking to me because that wasn't the reason for the channel, I mean, I think so that kind of energized me to think to myself that, you know what, it looks like this is something that people are hungry for and that they want to learn, and they feel like, that they want somebody to explain things in an easy to understand manner. And I think that's kind of just given me some optimism on, that look, it is making a difference in some people's lives.
Yeah, and have you had any doctors come back and say, "Hey, I watched this case and it actually improved outcomes in my practice"?
I think not that specifically. What I've had is I've had, quite a few physicians come and tell me that I didn't realize that that could be done. And now I'm so interested in learning all the techniques related to that and the anatomy. And I'm just amazed that we can do these types of things, even though I'm in the vascular world, so to speak. And I
Yeah.
think that's been one of the biggest compliments, is just somebody saying that, wow, I can't believe we can do these types of things. It's amazing.
Have you ever faced any skepticism about your methods or educational approach? And if so,
No, not
no?
really, because I'm not really trying to sell myself as some kind of, great, physician. What I'm trying to do is just show basics of all these things. What's the anatomy as I understand it? Here's how I look at it when I look at these, whether it's an angiogram or a patient evaluation or somebody I'm treating that's the so-called no options. The way I always try to go about things is saying that, look, there's many ways to do these things that still follow the guidelines. This is kind of the way I look at it in this situation, and this is kind of the way I try to approach it. I mean, the more I learn about all this stuff over the years, I mean, look, I've been doing this now 25 years.
Yeah.
I still feel like I'm learning and you know, the more you learn about something, the more you realize there's more to know.
Exactly. And I love that way of thinking. And that's why, it's interesting. I'd love to, hear how you see the education for physicians evolving on your channel. Do you have anything in the back of your mind that says, you know what, I need to do X, Y, and Z video, especially with the bioabsorbable stents coming in, the new retractable scaffolding coming in. You
Mm.
also have, we haven't even discussed a new minimally invasive bypass called the detour system or PTAP, which
Right.
I'd be curious if that's even in your future.
Yeah, I mean, I think all the above, right? I mean, it's just finding the time to do these things is probably the hardest thing, right? It's like it takes a
Too
lot of
busy
work.
saving those piggies.
Yeah, it takes a lot of work, as you can imagine, after hours.
Yeah.
And remember, it's not just putting a talk together. Anybody can put a talk together on all three of those topics, but it's making it so that it's engaging and interesting to to our younger generation who, you know, let's face it, it's a different generation than my generation. The attention span is shorter and people want a quick fix. And so trying to make something that's interesting, but not to the point where they're like, oh, this is so boring. I don't want to watch this. So it's a fine line.
We have a patient that Anna that wrote in and she wants to know. So I want to get in so those in the studio audience can actually get ready to ask some questions as well. But Anna wants to know what's the mechanism of action for balloon angioplasty? Because it would seem that if you expand a balloon and you're pushing plaque aside, as they say, that wouldn't you think it would just bounce back like a sponge?
Yeah, no, I think that's it's probably it's not an inaccurate statement. I mean, the way to think about it is that in general, angioplasty is a controlled tear, or the fancy medical word is dissection of an artery. So what you're doing is you're kind of tearing the artery, but not lengthwise along the artery, but kind of like a cross section. And by tearing or creating these little micro tears in the artery, the hope is that you cause that micro tears, then you dilate it with a balloon so it gets bigger, and then you want it to heal larger. The more calcium that it has, whether it's on the inside of the blood vessel or in the inner wall, the more likely it is to kind of you dilate it and it just slowly kind of retracts and shuts down. That's so-called recoil that they talk about, or restenosis. And so that's where all these devices come through, right? Where we talk about vessel preparation. How do we remove the plaque, whether it's soft plaque, calcified plaque? And plaque is just a buildup of atherosclerosis, you know, that fatty buildup inside blood vessels, which happens throughout the body and obviously in the legs as well. And so the idea is that by trying to remove as much of that as you can, then the likelihood of a better result after angioplasty is increased. And then the idea about using technologies that have different drugs to help reduce or slow down that healing process so it doesn't become over exuberant and narrow the blood vessel down too much is where all these things start coming into play. And so I think that's where we're really studying a lot of this stuff and trying to become experts at it and studying it in the lab and so forth. And I think we have a long way to go. But she's absolutely right. You do an angioplasty. The idea is that it pushes the plaque or you know, kind of crushes it to the sides. And it, you know, a lot of blood vessels with calcium will narrow back down very quickly or will recoil. And in those cases, if we're able to, we can sometimes put in a stent. There's various stents out there that, you know, we use. And that's what the stent is for, is to try to keep that blood vessel open after you've treated it.
And that's where we had talked a little bit before we had started taping. Becky wants to know about what if the stent or what if the vessel closes back down literally days or just a few months after they've used this balloon. And how do you know if it's clot or if it's scar tissue? And what questions should she ask her doctor before having yet another angiogram?
Yeah, I mean, if somebody's treated you with a stent or an angioplasty and that blood vessel or the stent has closed within a few weeks, I mean, the likelihood that that's most likely going to be something where it's clotted or closed off. But it's always a combination, right? Maybe the stent wasn't deployed properly. Maybe the stent wasn't dilated as big as it needed to be. Maybe the blood vessels above it are abnormal and the flow wasn't good. And maybe the blood vessels beyond it weren't good. And all those things can factor into, you know, can all make a difference in terms of blood stents or balloon treatments not staying open. But I think if something closes down very quickly within a few weeks, you can bet that probably there's some level of clot there, and that's a very different treatment that somebody comes back 6 months or a year later, and it's been slowly narrowing down over time, right? That's
Mhm.
that so-called scar tissue or intimal hyperplasia. So I think that requires some investigation to figure out.
And especially before yet another angiogram, unless it's an acute situation.
I think that's
And we
where
have
you got to figure out. Yeah.
and we have Douglas. Douglas, go ahead and unmute and ask Dr. Tumala your question.
Yes, sir. I was great. Congratulations. You really do a great job explaining this.
Thanks, thanks. I
Really
appreciate it.
do. And do you ever think we will, in the very beginning, some point, find out how to stop the plaque from buildup in the very beginning? Do you ever think that medicine will get to that point where we can figure that out in the very beginning, like take some kind of magic pill? I don't know. I can't say that, but you know what I'm saying?
No, for
Where
sure, for sure. I mean, I think if you look back, I think prevention is the biggest thing, right? But prevention starts with our diet and not smoking and and getting lucky with our genetics, who are our parents. I mean, that's a big thing too. But I think the other thing too is, look, if you have high blood pressure, get it treated. If you have diabetes, get your sugar under control and do all the things needed to do that. If you have high cholesterol, then you really should be on a statin medication to lower the cholesterol and deal with that. Because by doing that, you improve your chances not only of kind of reducing the amount of plaque you have in a blood vessel, but definitely stabilizing it, but hopefully slowing down or preventing the progression or of it getting worse over time, because that's the biggest thing. And so we do have therapies available today where you can kind of slow the process down or at least make it, where things don't get bad very quickly. And I think that's a big, big thing you can do is all those medical risk factors we talk about, diabetes, high blood pressure, high cholesterol. If you smoke, stop smoking. If you have kidney disease, get that checked out by your nephrologist or kidney doctors and make sure you take your medications and diet. I think those are the biggest things. But
And
right
doctor,
now, we don't have one pill that we could take that does everything. Yeah. I mean, I think right now there's people looking at, gene therapy and stem cell therapy and stuff like that for kind of making new blood vessels in certain parts of the body and things like that. But we're not where we need to be.
and what about walking as medicine?
Walking is a very important thing, but remember, a lot of people may have injuries or disabilities or things like that, which prevent them from walking. And so I think in those cases, it's a very difficult situation. If you have the ability to move around, I think moving around, whatever that means, walking around the block, walking down the street, back and forth in the driveway, all those things can make a big difference. And actually, we know that exercise programs before treatment and even after any type of treatment makes a big difference in terms of how successful your outcome will be. But a lot of people can't do that for various reasons.
Yep, it's so true. And we have Marcia. Marcia, go ahead and unmute and ask Dr. Tumala your question.
Hi, Dr. Tamali, and congratulations.
Thank you. Hi,
Um,
how are you?
Something you just said sparked my question. You were talking about everything that we can do, quit smoking, take your statins if you have high cholesterol, etc. And my question is, as someone with PAD, after diagnosis, I completely changed my lifestyle. I eat healthy for the most part. I mean,
Yeah.
I eat healthy, I walk a lot, I quit smoking, um, so forth and so on. And my cholesterol went from crazy, crazy high while I was on statins to like really low. And
Mhm.
I've been on statins the whole time.
Yep.
Is there any reason, and I'm blocked up again, I've had a couple of interventions that reblocked, but is there ever a time if you have changed your lifestyle and you do have good cholesterol, but you have PAD that you could be off statins?
Off statins, you said? No,
Off. Yeah,
no.
because
Yeah.
no.
Yeah, yeah. Once you're on it, I mean, in general, if you need to be on a statin, and I'm sure you have a cardiologist that's managing that, I assume, you
Mhm.
typically are going to be on statins for life. And that's the way it is.
Even if I've changed my lifestyle and drastically lowered it through lifestyle, you still think it's
So
necessary?
yeah, so the way to think about it is that, you can talk to your cardiologist about I've changed my lifestyle, my diet has changed. I'm as thin as I can be at this point. I've optimized myself. Let me see how I do when I stop the statin. I bet you your cholesterol will be better, but it'll still be high. Because remember, there's a lot of genetic components to this stuff. But if you can have a normal cholesterol, that means all the HDL, LDL, triglycerides, all that without a statin, then you don't need to be on it. 100%.
Yeah, that I'd like to experiment with it, but I also don't want to take any chances. But I know, I mean, my triglycerides were like out of sight. My cholesterol was out of sight, and now they're like low, low, low.
But the way to think about it, Marsha, also is that, there's probably a little bit of a genetic component there if it was that high, because, even with
Mm.
diet, your numbers can be high, but I know people where their cholesterols are, 800 and their triglycerides are 300, 400. There's a genetic component there. I think a good
Well,
discussion with your cardiologist really make a difference here.
I think it was all the pizza and potato chips I was eating,
Uh,
but I don't know. It might have something to do
yeah,
with it.
that doesn't help. Yeah, of course.
Yeah.
And we have one more
Thank you.
question from our studio audience. Marie, go ahead and she wants me to ask it. Okay.
Okay.
She says, if we have it in our arms, what can we do to help with that? It's very rare, but we have several people actually in our group. We've had a couple where their fingers have gone gangrenous before they've even
Yeah.
gone into treat. So I would love to have a little education offered on PAD in the arms, the symptoms, where the blockages occur, and possible treatment options, and the discussion you should have with your doctor.
Yeah, I mean, I think the way to think about it is atherosclerosis is a global process, right? It doesn't just happen in the arm or the leg or the heart or the brain. I mean, basically, you get it all over the body. It's happening all the time when you're in that phase. And depending on you and your makeup, some people show up with a heart attack or chest pain or heart problems first. Some people show up with a stroke. Some show up with leg problems first. And other people show up with, more rarely problems with their arms. I think with the arms, it's a little bit tougher. You have to really figure out, is it related to blood vessels? That's number one. Number two, do you have an underlying blood vessel problem, known as a vasculitis? That's a common thing we see. And then I think the third thing is where the level of the blockage is, and is it something that can be treated? The tools and the guidelines we have for treating blood vessel problems in the arms are not the same and diverse as the legs. I think we know more about the legs and we still have a lot to learn, but in the arms is a little bit different situation. But any vascular doctor you see should be able to evaluate you and see what your symptoms or problems are. One of the most common ones is what they call subclavian steal, which is just a narrowing in the artery that goes to the arm, but it also gives blood flow to the back of the brain and so forth. So some people with a narrowing in that artery will have dizziness, blurry vision, headaches, nausea, things like that when they exercise the arm, this way. And then some people, if they've got, like you said, lack of blood flow in the fingers or gangrene and so forth, you really have to figure out the problem. It's similar to, you got to figure out, you have to test them and see where the level of blockage is. That'll help determine treatment. But most people will still undergo some level of a workup for any type of vasculitis, just in case.
Fantastic. Okay, so our final three questions, and these are our deep ones. These are for we have
Yeah.
three major educational series that we do that air actually in our radio program as well, the Heart of Innovation on KDOW in the San Francisco Bay Area, which by the way, I'm going to get you to come on as a guest co-host sometime, just FYI.
Okay. All right.
You're just fantastic. Um, but these ones, you got to be specific and really think hard, okay? They're very personal. Um, Journey to diagnosis is the first one because we know that lack of diagnosis is a huge problem and misdiagnosis is a huge problem.
Mhm.
And we know in general that you have a million cases like this. But we'd love for you to just think of one that would be, really interesting to people where someone was misdiagnosed. It had you scratching your head about how in the world this patient was not diagnosed sooner and what you wish would have happened differently with that patient.
Yeah, I think where you see it the most is you got to remember that anybody that has peripheral arterial disease and symptoms, the symptoms are not always classic. Everybody always thinks about, I walk a certain distance and I have pain and discomfort in my calf or thigh or whatever it is. But in reality, if you look at everybody that has peripheral arterial disease and symptoms, only 15% show up as the classic claudication symptoms. And then a small percentage have end-stage peripheral arterial disease. Majority of patients really show up with atypical leg pain. And so if you're a primary care physician, you can imagine how difficult it is to figure that out. And so, somebody comes in, they're 50, maybe they're 70, and they say, oh, my legs bother me when I'm sleeping, or my toes, or I'm walking and I have some discomfort. The assumption is, oh, don't worry about it. It's probably arthritis, it's probably muscular. So I think that's the first thing. I think, having a high suspicion will really make a difference. I think the second thing where we see a lot of kind of delayed diagnoses, if you will, would be patients with vein disorders, varicose veins and swelling and skin discoloration and so forth. And a lot of patients are told either, don't worry about it, it's not a big deal, or you've got the so-called lymphedema, which is really a diagnosis of exclusion, and there's some other tests you can do. But, I have patients who are 70 that come and get treated for vein problems. And I'm like, I don't understand. I say to them, how come you didn't get this treated 40 years ago? Why are you suffering for so long? And in reality, it's just because they didn't realize it could be treated. And, so I think we have to just have a higher suspicion of what's going on. And like I said before, there's so much data and information out there. It's hard for any one person to know everything. And I think, that's why I tell people all the time, if you got a problem related to your GI tract, go see a gastroenterologist. If you have a problem with your spine, go see a spine person that's an expert in that area. If you have a heart problem, go see a cardiologist, because there's only so much that, primary care physicians, family practitioners can do, because they're dealing with so much information and so many other problems that it's hard to know everything about every area in the body. And so I think, the quicker you can see somebody who has expertise in this particular area, it'll make a difference.
And we do find a lot of patients are sent to an orthopedic surgeon. And I think all of us have issues with our back. We all have some sort of disc issue or nerve issue or something in our lower back that possibly could be treated, but it doesn't
Yeah.
necessarily mean that the symptoms you're experiencing are directly related to the back issue or the sciatica issue. That you really should, no matter what, before you have any procedure like a spinal fusion, we see that all the time, make sure
Yeah.
to get your arteries checked to rule that out. But
Yeah.
we did also have a vein issue. Just, I'm glad you brought that up, because
Yeah.
this poor patient was diagnosed with CVI, and they've left her literally. I didn't realize it could be as debilitating as she is walking with a walker and can barely put pressure on her feet. It's that bad now, 3 years later,
Yeah.
with nothing having been done.
Yeah. I mean,
So
patients like that, if they have a treatable cause, is a great thing. But there's our patients that have, symptoms that you're talking about that don't have a treatable cause, and that's a very tough situation, as you can imagine.
that one too. Okay, second to last, 6 minutes that mattered. The moment that mattered in your life or your career, it has to be a defining moment. So really think hard, a catalyst for change, a spark that led you in a specific direction, conversation you had, a clip in a film or a show or something like that, or maybe something you witnessed that was eye-opening. What was that moment or 6 minutes that mattered in your career?
No, I think for me, for a few years, I was dealing really with patients who had more neurologic problems because of my background and training in terms of strokes and things like that. And then I saw a live case of somebody treating as you said before, a no options, CLTI patient, somebody with really severe PAD. And when I saw that, it really opened my eyes that that was really my first passion and my first interest. And so that brought me back probably about 10, 12 years ago to this vascular space. And that's when I said to myself, that's really what I should be doing full time.
And not looking back.
Yeah. Yeah, that's right.
So the Pulse series. So share a case, a specific case with a big lesson for you. And this should be easy for you because you are our online educator of the year. So a case that you learned from that others can learn from. And I want you to describe the patient, the frustration with the case, and the lesson you learned and others can learn from it. It could be a success, it could be a failure, it could be include some ingenuity as well.
I don't know if there's one specific patient, but I think it's just a experience as a whole. And that is really setting up the proper expectations with whoever I'm treating. Because I think it's too easy to say, yeah, we'll take care of it, or we can do this. But I think if you see people in your office and you test them and you think to yourself, this is what we can do, but still setting up the expectation that, look, this is what we're trying to achieve, drawing it on paper, making sure everybody, looking on diagrams so they understand it. That goes a long way in terms of patient satisfaction, regardless of whether it's successful or not successful, because at least you're involving the person in the process so that they can see that, look, you know what? This is what they're trying to do. This is why they're trying to do it. And this is what the background is of why this should happen. It really makes a big difference. And I think that's one of the biggest lessons is talking to not only the patient that needs the treatment, but talking to the family members as well, because they have to take care of that person either way.
Fantastic. Thank you so much, Dr. Srini Tamala, Online Physician Educator of the Year for
Thank
2024 through the Global PAD Impact Awards, brought to you by the Global PAD Association. Thank you for all you do to not only save those limbs, exhaust all efforts to save limbs yourself, but also educate others through your online portal at Vascular Disease on YouTube to help them do the same, to give the patients the best chance at maintaining their limbs as well as their life.
Thank you, Kim. I appreciate all the hard work that you and others are doing, and thank you for having me on. I appreciate it.